So good morning, everyone. It's a pleasure to be here. Philadelphia is one of my favorite cities. I think some of you know I'm a graduate of Neshaminy High School. I won't tell you how many years ago, about 25 miles down the road. So it's always a pleasure to come to Philly, and it's always a pleasure, even more so, to be part of any activity that is organized by CHOP, and I'm very much looking forward to the rest of the day. I'm going to be talking to you today about a topic that has become something of a holy crusade for the rest of my career. This concept, this vision, and perhaps even a working reality of what has come to be known as a learning health system. And to set the tone for this presentation, I'd like to share with you one metaphor and one lesson from history. The metaphor goes to the picture on the left side of the screen, and that, of course, is Henry Aaron hitting his 715th home run that broke Babe Ruth's long-standing record. And let's think about something Henry Aaron might have done but didn't. Henry Aaron might have run to third base, turned around to everyone in Atlanta and said, "You know, I've proved my point," and walked off the field. Well, folks, that is exactly what I think this nation will do if we move a certain amount in our quest for the deployment of interoperable health IT, but fall short of realizing a fully blown, fully configured, fully operational learning health system for the country. So my last point, and probably most important point, is the one I'm making at the very beginning. Let's run all around the bases and touch home plate with our health IT effort. Henry Aaron, fortunately, did not walk off the field, as you all know, after reaching third base. The slide you see, the picture you see in the lower right, I don't know if any of you recognize this. This is a fairly famous picture of the Dumbarton Oaks conference that took place in 1944 when it was clear that the Allies were going to win World War II and that a new world organization was needed. And what happened in 1944 at Dumbarton Oaks was a gathering of the major stakeholders, major national stakeholders, the major Allied powers, who came together to agree on what the principles or precepts should be upon which the United Nations would be founded. And it is a fact of history that the agreement made at Dumbarton Oaks gave rise very, very quickly to a functioning United Nations less than 2 years later. And if you read the document that resulted from Dumbarton Oaks, you will see the shape of the modern United Nations, or the United Nations as it actually exists, almost completely reflected in that document. I'm not going to tell you now why I showed you this slide or showed you this picture, but I'll tell you at the end. So the three main themes of my talk will, first of all, establish what a learning health system is, or at least what I think it is and others think it is, and what a learning health system can do to promote individual and population health, which is really what we are all gathered here together in pursuit of. Then, as sort of a bridge concept, I'm going to very quickly tantalize you with a very interesting concept, the concept of a so-called ultra-large-scale system that really is a model for how we might build this learning health system for the whole nation. And then I will close with some very practical observations about how we might achieve a national scale learning health system, and how perhaps by doing the right things and touching the right inflection points at the right time, we might actually be able to do this faster than anyone might expect. I'm an eternal optimist, and I'm extremely optimistic about this. So I did not invent the concept of the learning health system, and I'm not sure who did, but I do know that the Institute of Medicine adopted this theme several years ago and made it the focus of many of its activities. And the IOM has evolved this verbal definition of the learning health system, which I'd like to share with you as a foundation for our discussion going forward. So according to the IOM, and I think this is an excellent definition, a learning health system is one in which progress in science, informatics, and care culture align to generate new knowledge as an ongoing natural byproduct of the care experience and seamlessly refine and deliver best practices for continuous improvement in health and healthcare. So that's a learning health system in words. Perhaps it's more informative and stimulating to think about what a learning health system might look like in pictures. So I share with you this graphic, and I would like to suggest that, at least to my way of thinking, this is what a national scale learning health system would look like. And I'll point out some features of this graphic. One is that it's clearly some kind of federation. It's a decentralized organization, and that the participants in this federation can take many, many different forms and represent many, many different kinds of stakeholders. And you see several, but not all of them, of all of the possibilities illustrated here. The second feature of a learning health system I would point out to you is the bidirectionality of the arrows that go from these participants in the system to the actual activities of the system, which are represented somewhat metaphorically in that cloud in the middle. And what the bidirectional arrows signify is a kind of reciprocity which underlies the entire operation of the system. The participants will contribute, and the participants will benefit. There will be many ways to contribute, and there will be many ways to benefit. And in the middle are some, but not all, of the features or functions that must be part of the operation of such a system. First of all, as a formal federation, it will require some appropriate form of governance, and I will just emphasize now, governance does not equal government. It will require patient engagement and the trust, and the public trust, that will only result from the engagement of patients who, after all, even though they are not directly represented in this diagram, must be seen as the center of such a system and its primary beneficiaries, and I'll be talking a little bit more about the patients and the learning health system in the panel this afternoon. A solid trust fabric must be part of this, and moving further down the cloud, there are the activities of the system. A learning health system must be able to either physically or virtually aggregate data that exists among different participants in the federation, conduct analyses on those data, and by virtue of those analyses, convert that data into knowledge, and then, speaking again to the outward flowing arrows, the learning health system must have the capability of disseminating that knowledge back out to all of the participants. So that graphically is what a learning health system might look like. So if you have something in place that looks like what I just showed you in that figure, what will it be able to do? I'm going to describe 3 examples out of probably 300 possibilities, and I hope I will stimulate your imagination to generate examples of your own. But before I do that, let me also mention a purpose for creating this learning health system that has become a bit of an anthem. As I think everybody in the room knows, it is widely believed, although I'm not sure it's exactly accurate, that there is a 17-year latency between the creation of a new element of biomedical knowledge and its widespread implementation in practice. I don't know if that number is 17 years or 10 years. Whatever it is, it's too long, and whatever it is, its order of magnitude probably is years. Well, one way of looking at the goal of a nationally scaled learning health system is to convert those 17 years, that 17-year latency, to 17 months, or maybe under certain circumstances, 17 weeks, or even 17 hours in the case of a public health emergency, which a learning health system can support, and that's one of the examples I'll describe. So here are just three examples of what the learning health system might do. One goes to nationwide post-market surveillance of a new drug, and in an era of personalized medicine into which we are very rapidly headed, it might turn out to be the case that the dosing algorithm for this new drug was pretty much okay, but not quite right, and that is becoming clear through the aggregation of the experience of very large numbers of patients made possible by this learning health system. Well, once the data from these patients is converted into knowledge that this is the case, that is the operation, the inward operation of the system. Through the outward operation of the system in its most sophisticated form, what geeks know as a digital knowledge object, in effect an implementable, computable set of decision support rules, could be transmitted out to the participants and almost immediately instantiated in the electronic health record systems of clinicians throughout the nation, in effect creating an instantaneous change in practice once that dissemination takes place. Example one. Example two, during an epidemic, new cases, and I think you can quickly see how this would be the case through the outward operation of the system, of whatever disease is the focus of the epidemic, can be reported directly out of the EHRs of clinicians as these new cases are diagnosed, up through the hierarchy, first to local and then to state and then to national public health, creating a kind of national geographic information system. That's the very rapid inward operation. And then in the outward operation, something is possible that actually the CDC is already experimenting with, that for those clinicians in areas that the epidemic has not yet reached, but areas it will reach soon, those clinicians can be alerted to be on the lookout for whatever symptom complex it is that describes this disease, because in point of fact it is known to be headed their way soon. This is an example of how a learning health system could be valuable operating on a time scale of hours, not weeks or not days or weeks. And third, consider a patient who faces a difficult medical decision. She could, using information that is, or using knowledge that has been created by and disseminated through the learning health system, make that decision based on the experiences of other patients like her in a very, very quick and efficient way. So these are just three examples of a multiplicity. Another point I'd like to make about a national learning health system is that it is a single infrastructure. One might look at what is happening now and come to the conclusion, and it's not an invalid conclusion, and it would be very unfortunate if this comes to pass, that what we might be evolving now as a nation is separate infrastructures to support different knowledge-generating activities, when in fact what we really need, and probably the only thing we can afford in the end, is one infrastructure that supports all of the activities that a national learning health system can support, and those are enumerated on this slide. Clinical, comparative effectiveness and translational research, the activities of public health, including surveillance, situational awareness, and interventions, as I described in that example, and activities focused on quality improvement, including health process and outcome research, and best practice dissemination. The learning health system, once realized on a national scale, would provide one infrastructure for doing all of these things. Somewhat redundant slide here, but just to drive these points home even further, the learning health system has to be able to do things in order to realize its objectives. It has to be able to aggregate data physically or virtually. It has to be able to analyze that data, and it has to be able to package the results in some implementable way so that the knowledge can be efficiently disseminated back to decision makers. And of course, it must be able to govern and sustain itself and maintain public trust. A tall order, but it's very important to emphasize that without the capability to do all of these things, a national system will not be stable and will not survive. So there's been a lot of thinking about what a national scale learning health system might look like. Just to share what seems to be an evolving consensus, and I've alluded to some of these points before. First of all, it has to be a federation of some type, and I want to be clear to everybody in this room, I'm not talking about a centralized database of any sort, and certainly not about the kind of centralized database that drew the death panel observations from certain political factions in this country when some of these ideas were first surfaced. This is a federation, and entities will actually hold on to their data, will manage their own data, will hold on to their data and not move it from where it is to any other place until there's a reason to move it. And with some evolving technologies, there may not be a reason to move it at all because of methods that are developing for virtual aggregation and analysis. I've mentioned the other 2 points of public trust and participatory governance, and as I move into the second part of the talk, I will describe in detail how the national scale learning health system must function with all of the characteristics of what computer scientists call an ultra-large scale system. One of the features of an ultra-large scale system is minimal standardization. What is very, very important to recognize is that national ultra-large-scale systems develop through much like the internet, through a very, very small but extremely well enforced set of standards that enable the basic operation of the system, but around which all of the participants can innovate in kind of a bottom-up but still very rigorous way. This is how the internet developed. This is what has made the internet so successful. And while the national learning health system is not quite like the internet in many, many respects, I believe it has to be like the internet in this respect. Minimal, highly torqued down standards around which innovation can develop. So just a little bit more now about this notion of an ultra-large scale system. One of the activities I was very fortunate to have had the opportunity to initiate when I was with the Office of the National Coordinator was a very productive effort that was conducted by the Institute of Medicine. It was a series of 3 workshops that took place in 2010 and which led to a report released in preliminary form in December of 2010, but in final form early in 2011. A report entitled The Digital Infrastructure for the Learning Health System, the Foundation for Continuous Improvement in Health and Healthcare. And most of what I'm telling you this morning in a very, very short period of time, if you want more detail about it, is contained in this report, which you can access on the internet at the URL, which is seen on the bottom of the slide. At the second of these 3 workshops, we were very, very fortunate to have as participants in the workshops several members of the computer science community, not healthcare people necessarily, but very, very sharp computer scientists who had participated in 2006 in work sponsored by the Department of Defense, but actually conducted at the Software Engineering Institute of Carnegie Mellon, which investigated why so many large-scale information technology projects fail. And what resulted from this investigation was a recognition that these large-scale projects are, by and large, completely improperly conceptualized. And they were conceptualized by a direct scale-up of the principles that are used to design smaller-scale systems. The point and the outcome of their investigation is that you can't do it this way. When you're designing a system to work at very, very large scale, you have to work from a completely different set of principles. And out of this work came two publications relating to ultra-large scale systems and the propounding of this concept of an ultra-large scale system. I highly commend these readings to you. Both of them are available on the web. If you just Google ultra-large scale system, both of them will come up. What we recognized in the IOM deliberations about the learning health system is that it must be a ultra-large scale system, and it must function based on the precepts that make ultra-large scale systems successful. And some of these principles, I won't share all of them with you, are seen on this slide. They include that an ultra-large scale system must be viewed as a socio-technical system with the people and the technology and the psychology and the sociology and the organizational factors all integrated and viewed together as equally important. Ultra-large scale systems must be decentralized. Ultra-large scale systems must promote innovation around, as I said before, a minimally sized set, but absolutely essential and highly torqued down set of standards. They must be able to respond to a diverse set of requirements which, moving to the next bullet, are going to change inevitably, so the system must be designed not to be static, but from the outset to be something that is in continuous evolution and redeployment and actually composed of changing elements. This must be a system that can redesign itself in real time. This is a very different concept from the way most IT projects had been previously conceptualized. So we took away from this, and you'll see this in the IOM Digital Infrastructure Report, a kind of worldview of what the National Learning Health System must look like. So how can we get there? And how can we get there perhaps more rapidly than the magnitude of the task at face might lead us to believe is possible? Well, first of all, I want to emphasize that the National Learning Health System is not a one-off with respect to current federal health IT planning. In point of fact, it is very much on the critical path, and if you look at this slide, which I took literally from the 2011 revision of the Federal Health IT Strategic Plan, you will see that the pinnacle goal, Goal 5, of this plan, which just precedes the ultimate goal of transformation of healthcare as seen in the plan, is the achievement of rapid learning and technological advancement. So the learning health system is a key feature, indeed the pinnacle goal of the federal health IT vision. Another point I would need to add, and I think this is a critical element of a strategy moving forward, is a recognition that meaningful use is necessary but not sufficient for a learning health system, and there are many reasons and many ways to see why this is true. One of them is to recognize what meaningful use is legally. Now I'm sounding like a government employee, which I guess I was. But if you read the statute, you will recognize very quickly that meaningful use is a status. that is achieved individually by those eligible professionals and hospitals that are called out in the HITECH Act. Achieving that status is realized by achieving several objectives, and once you achieve those objectives and thus that status, several things happen. Among them, you receive the meaningful use incentives payable through Medicare and Medicaid. By contrast with meaningful use, which is an individual status, the learning health system is, excuse me for being circular here, a system. It includes these professionals and hospitals, but it's broader in its scope. It includes a whole range of additional kinds of entities that you saw on that graphic that I showed earlier. And to function as a system, this LHS requires several elements that are not contemplated by meaningful use, nor would it make sense to contemplate them as part of meaningful use, because meaningful use is a status, not a system. So the learning health system will have goals that exist at a higher level of aggregation, at the level of the operation of the system, not at the level of the individual components of the system. That is, in fact, what a system is. I already mentioned that the learning health system will have a much broader set of stakeholders than those who are eligible for meaningful use. And then, because it is a system, it will need these features of organization, membership, and governance that hold the system together and sustain it. But if you will, another way of saying that meaningful use is necessary but not sufficient for a learning health system is to develop a very simple, perhaps simplistic formula that meaningful use plus some delta will get us to a learning health system. So to parse that formula a little bit, it's worth looking at, first of all, what the learning health system might inherit from meaningful use as things move forward in the way that many people believe they will. The learning health system will inherit from meaningful use very, very large amounts of digital and thus computable health data. If you mash up all of the predictions that have been made and make the perhaps specious assumption that the mashing up of all those predictions will generate the truth, then the truth is something like 80% of the documentation of healthcare will occur digitally by something like 2019. So the learning health system will, going back to the IOM's vision of learning as a byproduct of care, have as a basis for that learning as a byproduct of care a largely digital base of information not too long from now. The learning health system will inherit substantial standardization, maybe not exactly the standardization it needs from meaningful use, but some substantial standardization, some significant health information exchange capability, some governance of health information exchange that's required by the HITECH Act, and a set of privacy and security policies which are also basic and helpful. But going back to the delta now, the learning health system is going to require a higher level of standardization than we might expect from meaningful use, because the learning health system requires aggregatability of data, not just exchange of data. The exchange capabilities that will result from meaningful use may very well turn out to be considerable, but the learning health system is going to require a very, very sophisticated bi-directional kind of information exchange that may or may not be contemplated by meaningful use. The governance of health information exchange will need to be extended for a functional learning health system to embrace that level of governance which is required to govern a decentralized federation. And it may very well be the case that the learning health system will require expanded privacy and security policies necessary to instill trust in the system. So where are we now? Well, we're further along than you might think, because I think it's safe to characterize the current state of affairs in the national evolution toward a learning health system as an archipelago. We have many, many, many islands. I call them islands of excellence, each of them bounded in its own way. Within its boundaries, a very significant component of learning health system activities in each of these organizations is already taking place. So we have, metaphorically, these islands, each of which is in itself a bounded learning health system. Some of the boundaries are corporate, some of the boundaries are around disease domains, some of the boundaries are even around use of certain vendor products. But we have islands within which many, many rich and important learning activities are taking place. Excuse me. So it may be that if we can implement a national strategy that, instead of starting from scratch, seeks to federate this archipelago of islands and bring them into closer operating harmony. There are some fancy words here from a paper I wrote 2 years ago that describe how this might take place, and I won't read them to you here in the interest of time. But the strategy, I think, is pretty clear that a very elegant way of thinking about how we might move toward a learning health system would be to go from this archipelago of disconnected islands, taking advantage of the sophisticated activity going on in many of these and harmonizing them in such a way that we will progress toward, over time, in stages, a national learning health system that could function as an ultra-large-scale system. Now back to Dumbarton Oaks and that slide I showed you originally. So next month, with the support of the Joseph Kanter Family Foundation, we're actually going to be holding a meeting that, it's a bit of a moonshot, but if it's successful, could end up being, for the learning health system, what the Dumbarton Oaks Conference was for the creation of the United Nations. You see a picture of Joe Kanter there. I don't know, some of you probably know him or of his activities. Joe is an 88-year-old, very successful business person who 20 years ago was diagnosed with prostate cancer and became very, very frustrated when he could not get data-based answers to any of his questions about the experience of patients who had problems like his and underwent different types of treatment. And he concluded, you know, you'd never run a business like this, you'd go broke. So Joe, right then and there, he's a very smart guy, invented the concept of a learning health system. He called it a data sharing federation, not a learning health system, but he invented the conference. So the concept. So I've been very, very fortunate to have gotten to know Joe and to have been able to suggest to him that we might be able to move the nation very, very quickly in the direction of a federated archipelago and thus toward a national learning health system by convening a conference very much like the Dumbarton Oaks Conference in 1944. So I will just share with you that I don't have the slightest idea how successful this conference is going to be, but we have had an enormously favorable response. We have the maximum capacity of 80 stakeholders coming to this meeting. It's going to be a meeting of individuals representing organizations overwhelmingly because the end goal of what we're calling the LHS Summit is for consensus and ultimate endorsement of a set of principles or a compact that would express the foundational principles that will govern and guide the development of a national scale learning health system. So I'm very, very optimistic about what might result from this effort, and it might, if it's as successful as I think it could be, take us a giant leap toward the goal of a national scale learning health system functioning like an ultra-large scale system, which is many people believe the only way something of this magnitude can be stable and successful. I'm just showing you here the different types of stakeholders who are represented or are going to be represented at the Learning Health Systems Summit. We have a number of representatives of each of these groups coming. We're, of course, hoping that those who are not physically present at the summit will be drawn into the planning and will ultimately become signatories of the compact endorsing this set of initial principles. So that brings my remarks to a close. I return you to Henry Aaron and the importance of circling the bases, touching home plate, and as we move toward a learning health system, taking full advantage for the health of everyone in this country of the investments we are already making in health information technology. Thank you. I think we do have some time for questions.
Yes, absolutely we do.
And if so, I'd be delighted to take your questions. If you don't have a chance to ask a question or catch me later in the day, please feel free to write to me. As some of you know, I do not go to sleep at night without going through my email. So if you write to me, you will hear back from me. Thank you very much. I hope you found these comments useful.